Question 46, which of the following additional findings would most likely be seen on echo? So echo, heart, and then we see a bunch of stuff about the heart. So we got a cardio question. 72-year-old man presents after nearly fainting while climbing stairs. He reports several months of progressive exertional fatigue and occasional chest pressure. It's just like so generic. It really doesn't tell me much. Physical exam reveals delayed carotid upstroke. Okay, delayed carotid upstroke is definitely important. And a harsh, late peaking systolic murmur at the right upper sternal border. Okay, so we've got the timing and the cardiac cycle, systolic, and the location, right upper sternal border. Lung sounds are clear to auscultation bilaterally. No JVD or peripheral edema is noted. Okay, and then what are we going to see on echo? What are we looking for on an echo? Well, first we should start with what's the problem. So let's go back to it. As always, right side, left side. This is the sternum. All positions take money. Okay, so we've got right upper sternal border. So this is the right side. Really, there's only one. So it's probably the aortic valve, and it's during systole. Therefore, it's probably aortic stenosis. Can we confirm that with the other findings they gave us? The late peaking murmur, right? So if we were to draw out on the x-axis, this is our time, and maybe on the y-axis, this is our intensity. This is going to be S2, and this is S1. So this will be systole, and then over here will be diastole. So the murmur would probably sound something like this. It's getting bigger and bigger and bigger, and then it gets smaller, smaller, and smaller. Does that look familiar? Maybe if I drew it better, it would, but this is supposed to represent our crescendo, decrescendo. Okay, so let's take a look at our answer choices now that we know it's aortic stenosis. Dilated left atrium. Okay, so this one actually makes sense. If we were to have our aortic valve here that was really stenotic and basically really difficult to get blood through, and then we had our mitral valve here. Over time, we're going to build up more and more pressure in this left ventricle. So some of this blood will backflow into the left atrium, and that can cause left atrium dilation because the left atrium is not built for that much load. So this one's totally possible. Let's keep that one in our sights for now. Next up, thickened ventricular wall. Okay, this is where it gets interesting because if we have our aortic stenosis and we have all this pressure in it over time, it's just going to get thicker and thicker, right? This is the hypertrophy process. In order to compensate for the extra pressure, the heart muscle itself gets stronger. So yeah, absolutely with aortic stenosis, you're going to have a thickened wall. And possibly you're going to have a dilated left atrium. So now we've got two choices that sound pretty good. Let's go through the rest to make sure we're not missing something. Reduced ejection fraction is not typical in early to mid aortic stenosis. It can be later on once you reach heart failure, but ejection fraction is actually preserved with most aortic stenosis. Right ventricular hypertrophy. Okay, so right ventricular hypertrophy, I mean, I guess if you took this scenario and ran it all the way through the lungs, right, went all the way through the lungs and then all the way back to the right side of the heart, then yeah, I guess that would be right-sided heart failure due to left-sided heart failure. But that, I mean, we're straying farther and farther from God here. If thickened ventricular wall is the first step, dilated left atrium is the second step, right ventricular hypertrophy is like maybe the fourth step. So I'm going to cross this one off. Even though technically it could happen very late in the disease, so could reduced ejection fraction. Thinned ventricular wall is incorrect because we're dealing with increased pressure over time. The heart is going to try and compensate for that by hypertrophying, so you'd get a thicker wall, not a thin wall. Thin wall would be dilated cardiomyopathy. We're talking about hypertrophic cardiomyopathy. And so I touched on this earlier. For between these two, always go back and read the question a second or even a third time just to make sure you're not missing anything. Which of the following additional findings would most likely be seen on echo, right? So the key here is most likely. And as we discussed in our poorly drawn image here, most likely the first thing that's going to happen is going to be this hypertrophy, this response to the load. And then over time, you're going to get more and more hypertrophy and more pressure that accumulates with these heartbeats that eventually you will regurgitate into the left atrium, and eventually you'll get dilation, and eventually that'll go to the lungs, into the heart, and so on. So out of these two, I would pick left ventricular hypertrophy as the best choice because it's going to be the first thing that happens. So the correct answer here, this is a tricky one, but the correct answer is B. Now, if we were to see this question on a test, I would definitely want to know what the statistics were on this question, but maybe 40% of people get it right, maybe 50%, maybe it gets thrown out. Either way, this is still good logic. So keep the logic in the back of your mind when you're approaching similar questions in the future.